Um, Assalamu alaikum, everyone. My name is Ismail Abdullah. I'm a fourth year medical student, and inshallah, today I'll be going over uh, some high yield concepts in anatomy, uh, some concepts that I believe will show up in the exam. Um, of course, through the lecture slides and the review session Dr. Elena gave, I think. So, yeah, let's start. So, one thing about anatomy, you have to always whenever you see a muscle, whenever you see an organ, you have to know the van, which is like the veins, the arteries, and the nerves. And as well, if you can consider the lymph nodes, the lymph drainage for each and every muscle and organ, that would be amazing. Because these are technically like free marks. So yeah, let's start. So inshallah, I'll be going over these concepts. Starting from the abdominal wall all the way to the urinary system, kidneys. We'll be going over some radiological images, and at the very end, I'll be having two clinical scenarios to discuss, hopefully to, foster your learning on BPH and prostate cancer. So let's start with the first question. Um, the first question is, which muscle of the posterior abdominal wall is going to flex the thigh at the hip and is innervated by the femoral nerve? So this is a very straightforward recall kind of question. So the answer is going to be iliacus. Now, as you can see here, let me just try to change the pointer. Okay, so iliacus is, I think it's like the muscle that's being supplied by the femoral nerve, and it's responsible for the flexion of the hip. Okay. The other posterior abdominal muscles, like the quadratus lumborum, psoas major, they have different supply. They're not the femoral nerve, and as well as different function. Cool. The second question is, a medical student examines the posterior abdominal wall during a dissection. Which muscle originates from the transverse processes of the lumbar vertebrae and inserts itself into the lesser trochanter of the femur? So what do you think the answer is? And that would be the psoas major. So it's from what I heard and from what I've also seen in the slides that these are concepts that you might want to know. They're because they're in bold and could show up in the exam. So it's very important to know their insertion and their origins. And they're just a few muscles, by the way, so they're not that hectic, yeah, inshallah. So it's a psoas major. Okay, moving on. During a posterior abdominal dissection, a medical student identifies a muscle originating from the iliac crest, okay, uh, and it inserts at the 12th rib. So what is the action of this muscle? So first of all, we need to identify what muscle is this. So this will be the quadratus lumborum. Okay, so what's the action of quadratus lumborum? As we saw in the previous slide, that would be lateral flexion of the lumbar spine. Great. Okay, moving on to the fourth question. So, a 63-year-old man comes to the emergency department with back pain, weakness, shortness of breath. Upon examination, there was an aneurysm of the abdominal aorta at the aortic hiatus of the diaphragm. Which of the following pairs of structure would most likely be compressed? And a follow-up question, which level? Okay, so first of all, we need to break it down. So a patient coming with back pain, weak, shortness of breath, so something acute. Then it says here that they're having an aneurysm of the abdominal aorta. So when we say aneurysm of the abdominal aorta, it's basically when the walls of the aorta, the blood vessel itself, the artery, weakens. So when it weakens, it's going to dilate, and that's going to form um, like a pulsatile mass in the abdomen, okay, which is the AAA, abdominal aorta aneurysm. Okay, so the question here asks which pair of structures would most likely be compressed? And it also mentioned that it's at the aortic hiatus of the diaphragm. So what do you think the answer would be? Yeah, it's C. Okay, so it's the azygous vein and the thoracic duct. And at which level does the aortic hiatus open in the diaphragm. Yep, at T12. Okay. So these are the structures, these are the different openings. So the vena cava, the inferior vena cava, opens at T8 and it passes the inferior vena cava and the right phrenic nerve. The esophagus opening or the esophagus hiatus at T10. Make sure that there's vagus nerve through it and some esophageal vessels and the esophagus itself. And at T12, you have the aorta and passes through it the aorta, thoracic duct, and the esophagus vein. These are very important, could show up in your OSCE, could show up in the SEQ, and could show up in your MCQs as well. Okay, so a 55-year-old female presents with severe abdominal pain and back pain as well. Pulsatile mass is palpated at the midline just above the umbilicus. What is the next best diagnostic test to confirm the suspected diagnosis? Okay, so what are your keywords here? So first of all, severe abdominal and back pain. Again, acute, this is something acute. Pulsatile mass is your keyword. When you see the word pulsatile mass at the midline, just above the umbilicus, that indicates that this is an abdominal aorta. So what would be your best next diagnostic test to confirm this suspected diagnosis? Okay, so you said X-ray. Now, um, I don't know about that. Do you think that X-ray um, is going to show you like an aneurysm? We do not have time for others. No, actually, in a clinical setting, okay, because you don't have time, okay, you need to keep in mind that it could rupture, okay, and if it ruptures, it has a 90% mortality rate. So the fastest and literally the best diagnostic test you could do is you can just do a plain ultrasound. Because when you do an ultrasound, it's literally going to show you that it's pulsating and it's going to show you that it's dilated as well. Okay, an X-ray, you could need to inject certain materials to see, the exact flow of the blood. You would need to be like very, very, uh, meticulous looking at it and stuff. So, and honestly, it wouldn't just show you the aorta clearly. So, an ultrasound is just going to show you right there. It's pulsating and it's dilated, especially in an acute setting. Okay. Did you get it though? Was it clear to you what I meant? Okay, let's move on. So this is a 60-year-old male, presents with severe abdominal pain radiating to the back and hypotension. Imaging reveals ruptured abdominal aortic aneurysm. Which landmark would help localize the usual site of the aneurysm? Okay, so indirectly, this question is trying to tell you what's the most common site of abdominal aortic aneurysm. So where do you think it would happen? Okay, yes, it's going to happen exactly just above the bifurcation of the aorta at L4. That's usually one of the most common sites of aneurysm. Okay, a 28-year-old man complains of back pain after lifting a heavy box. Radiological examination revealed intervertebral disc herniation between L4 and L5. Which of the following nerves is most likely affected? What do you think? Any guesses? C, the lumbosacral. Yes, it's correct. Why it's the lumbosacral? Because as you can see here on the image, okay, first of all, lumbosacral is the only one that would, form like a trunk from L4 and L5, okay? If we look at the others, the femoral comes from comes from L2, L3, L4. The ilioinguinal is purely L1, and the genitofemoral comes from L1 and L2, I think, right? So the only one that's from L4 and L5 would be the lumbosacral here. All right. So moving on. This is a 25-year-old male presents with pain and a palpable mass in the scrotum. Upon examination, yeah. Okay, so upon examination, the mass does not trans-illuminate. Doppler ultrasonography confirms a varicocele. Why is a varicocele more commonly found on the left side? So, what do you think? This is a pretty high yield concept, so it's gonna show up, I think. Yes, it's gonna be B. That's correct. Okay, so uh, this is more of like an anatomical reason behind why varicoceles are more commonly found on the left side. It's because, the left vein, the left renal vein, okay, uh, two veins drain into it, the suprarenal and the left gonadal vein, either testicular or ovarian. So usually, if let's say there was an aneurysm or a tumor at the hilum, for example, right here, okay, usually what would happen that there will be compression. So due to this compression, there will be high pressure on the left renal vein that would lead to backflow of blood, causing, you know, causing a varicocele in the left side of the scrotum. What is ERP? Someone mentioned in the comments. Oh, okay, cool. So let's move on. All right, so this is a 35-year-old woman undergoing surgery for an abdominal aortic aneurysm. During the procedure, which structure is most at risk of damage due to its anatomical proximity to the abdominal aorta at the level of L4? So, what do you think is a structure uh, the highest risk of being injured during this surgical process to repair the abdominal aortic aneurysm? Yes, it's going to be D. Okay. Now, uh, sometimes there could be, confusion, like why not pancreas, right? Because, in the slides, it's written in the interior relations of the abdominal aorta, you'd have pancreas, splenic vein, you'd also have the mesentery, and you'd also have the duodenum, the third part of the duodenum. But if you look carefully, it's the duodenum crosses over the abdominal aorta. So it's going to be the one with the highest risk of getting injured. Okay. Okay, so moving on. A young boy is brought to the hospital after a bicycle accident and possible pelvic fracture. While awaiting a CT scan for the pelvis, the physician proceeds with a focal neurological examination in testing the child reflexes, which of the following nerves would carry afferent impulses of the cremasteric reflex. So, what do you think the answer is? Yeah, it's going to be the genitofemoral nerve. This is because, the genitofemoral nerve um, has two branches, the genital and the femoral. So definitely like the femoral is going to have like some sensory function over the thigh of the skin, the skin of the thigh. Okay. So whenever a physician would just like, you know, to get anything and like strike it slowly over the skin medially, that's going to cause the scrotum to contract, pulling the testicles upward, and that's the cremasteric reflex. So we ensure that L1 and L2 are functioning. But someone said that this is not going to be tested. Okay. Uh, moving on to the other question. A 58-year-old man is presented, sorry, a 58-year-old man is presented with edema of the lower limb and enlarged superficial veins of the abdominal wall. Examination of radiographs and angiograms reveal obstruction of the inferior vena cava just proximal to the entrance of the renal vein. This venous blockage may result in dilatation of which of the following veins? Oh, okay. So what do you think is going to be the answer for this one? Okay, so you said it's C. Do you mind sharing why do you think so? Yeah, I'm just gonna go forward and explain it to you. So, if you look carefully, first of all, it says that there's an obstru okay, you sent an explanation. There's no direct attention. Yeah, that's the point. Okay, so let me explain it to you. So first of all, in the question it says that there's edema, which means there's an obstruction, just exactly what the angiogram showed us. But it's proximal to the entrance of the renal vein. So this is your keyword, okay, or key phrase, let's say, entrance of the renal vein. So if we look carefully, okay, none of these options, okay, except the left suprarenal vein is within a close proximity to a renal vein. So you have this is the right renal vein right here, and this is the left renal vein. So if an obstruction would happen next to the entrance of the renal vein, and it's more to be common on the left renal vein, okay, uh, the left suprarenal, since it drains into the renal vein, is going to be dilated, given that given that the inferior vena cava would be obstructed. So there will be backflow of blood, high pressure, leading to its dilatation. This is why the answer would be left suprarenal vein, and not right hepatic vein, because that's gonna be a bit higher. All right. So, um, which nerve emerges from the medial border of the psoas at the brim of the pelvis and supplies the medial surface of the skin of the thigh? So this is a pure memorization, honestly. It's a recall question. Um, okay, so uh, it's not going to be A. It's going to be C, actually, because it's a medial surface of the skin. So you have two ways to know that it's obturator, not genitofemoral. It says that it passes through the medial border of psoas at the brim. So usually a brim is like a key word here, okay? Because like it follows it, but it also supplies the medial surface of the skin of the thigh. So the thigh, the skin, and the interior portion, you have medial, anterior, and the flexors, and you have the lateral. The medial is supplied by the obturator. The very interior, okay, is supplied by the femoral, and the lateral is supplied by the lateral cutaneous nerve. So this is how it really goes. And yeah, okay, so I'm moving on to the next question. A 58-year-old woman presents to the ER complaining of severe right-sided low back pain. Examination revealed loss of sensation to the suprapubic region and posterior lateral gluteal. So a CT scan revealed a mass in the right kidney, which of the nerve was compressed by this tumor. So your keyword pretty much here is, what supplies the suprapubic region? Because, this tumor compressed a nerve, causing loss of sensation there. So what do you think the answer would be? Um, no, think again. You're close. Yeah, it's gonna be A. Okay, so if you look at the table here, so in the slides, it says lower skin of the interior abdomen. That's gonna be the iliohypogastric. The ilioinguinal is going to, give sensations to the skin of the groin and the scrotum as well. The femoral, as I mentioned earlier, it's going to be the anterior skin of the thigh, and the obturator will be the medial skin of the thigh. But anything in the lower portion of the abdominal wall, like the suprapubic region, that's going to be supplied by the iliohypogastric. Okay. So moving on, which lymphatic structure serves as the origin of the thoracic duct? Yes, that's going to be A, the cisterna chyli. Okay. And so if you look at the diagram right here, this is cisterna chyli right here, and it's somewhere between L1, L2, and it's usually formed when the right and the left lumbar lymphatic trunks uh, and the intestinal trunk, just like all merge in, they're going to form the cisterna chyli. So, yeah. And then the thoracic duct, as it enters um, as it, enters the thoracic part of the thoracic part, like as it passes the diaphragm, is going to be called thoracic duct, and then it continues. Cool. So, 45-year-old male presents with a renal tumor. The primary lymphatic drainage of the kidney is to which lymph node? Yes, it's going to be correct. It's going to be B. It's called para-aortic or lumbar. Okay, so usually these are two interchangeable terms on how it's going to be asked in the exam. But so let's move on. This is a tumor in the testicle, metastasized to which of the following lymph nodes first? What do you think the answer would be?
ايوه.
Uh, so- yep, it's going to be D. That's correct. So it's going to be the para-aortic lymph node. Okay, since it's going to, it just follows the artery pathway. So it's going to be, dumped in the renal veins, like the renal arteries and stuff and all that. So, periaortic lymph node is the correct answer. Okay. Moving on to our 17th question. A 60-year-old female presents with a metastatic colon cancer. Which lymph nodes are most likely to be involved first? So we're talking colon. So that's going to be GI. And that's going to be C. Correct. So what's the other terminology for, you know, saying pre-aortic lymph nodes? What's other terminology to call that lymph node? Do you know? Okay, that's going to be the mesenteric. So sometimes they're going to say either pre-aortic or mesenteric lymph nodes. So these are interchangeable. Yeah, cool. Okay, moving on to uh, this question. It's a 40-year-old woman presents with flank pain, hematuria, palpable mass in the right lumbar region. Imaging obtained is on the right side. What is your diagnosis? Do you have a guess? We see stones in the ureter. Like, uh, it's not B. Um, Unfortunately, it's not B. Okay. Let me show you. Okay. So, first of all, the very first step, okay, before you look for stones, you need to identify and make sure that the kidneys are located in their right anatomical position. So, and always compare the right and the left side. So, take a look here. This is the kidney, right? And this is the pelvis. We can see here the pelvis, the major calyces, minor calyces are all visible to me. And this is the kidney right here. But where's the kidney here on the other side? So this is the kidney. It's right there. And these are not stones. This is actually part of the like the calyces. Okay. And this is an image of nephroptosis. Okay. And nephroptosis is so this condition usually happens when the perirenal fat, usually this is more common in women, by the way. Usually when there's like this rapid loss of weight, the perirenal fat, is going to be depleted, and that is going to cause the kidney to just drop, and it's gonna be stuck, of course, in the pelvis. Now, why does it drop? It's because the anterior and the posterior layer of the renal fascia, they're not fused inferiorly. Okay, they're yani, uh, they're shaped like this. Okay, but from down there, from inferiorly, they're not fused. It's not closed. That's why it's going to allow the kidney to drop. Okay, there are white spots in the pelvic region. Okay. I don't think these are stones. I'm not sure though. Okay, but I do not think these are stones. Uh, but for the sake of this question, I, I'm just targeting to nephroptosis. But I don't think these are stones. I'm not sure what those are because there's something similar down there too. So maybe it's just the imaging. But we have some pictures upcoming. Okay, but it's always very important. You need to, yani, try to think of first step when you look at the KUB, when you look at the X-ray, targeting renals, kidneys, I mean. First, you need to make sure that they're in the right anatomical position and compare with both sides. This is something very important. Okay, so a 35-year-old man presents with a recurrent urinary tract infection. Imaging reveals renal stone with a branching configuration resembling a stagged antler. What is the composition of this type of stone? Yeah, so this is staghorn calculi. Okay, perfect. Cool. So the answer is going to be C, correct? Now, first of all, you have two keywords here: the stag itself, the imaging, and the other thing is that it's a recurrent UTI. Usually, recurrent UTIs, okay, with staghorn calculi are talking about Proteus perimetalis, okay, and it's going to form this very high pH stone in the pelvis and the major calyces, actually, okay. and it's going to be composed of magnesium ammonium phosphate, yet thus the high pH. All right, so which of the following posterior relations of the kidney is most important for surgical approaches to the organ? So let's say if someone wants to do a nephrectomy, uh, renal transplant, um, which of the following posterior relations will be very important when it comes to, having surgical management to it? Between A and B. Okay. Uh, Actually, the answer is going to be, yeah, correct. The answer is going to be D. Why? Because, oh, sorry. Just a minute. Yeah, it's going to be D. Okay. And the reason behind that is because quadratus lumborum is a home for very important vessels, very important nerves. Okay. So you need to make sure that you identify the muscle, the nerves, the vessels, and try to not injure them when you're having a surgical approach. That's why it's very important to keep an eye at it. All right, moving on. So, yeah, sorry, I meant C. Okay. Um, cool. A 60-year-old male presents with severe right-sided flank pain radiating to the groin. The patient also complained of pain in the shoulder. Which structure is affected that led to this presentation? So this is a CT scan, and as you can see here, this yellow arrow, uh, is targeting something. So do you know what this is? So like before you want to discuss, the pathology, let's diagnose it. So what do you think this is? Okay, yeah, it's going to be an abscess. Okay, so this is an abscess, correct? Okay, and this is a psoas abscess. Okay, and you can compare with the other side. There's no abscess here. There's an abscess here. And as well, you can also notice that, there could be like a stone as well here. Anyways, so there's an psoas abscess, right? And then it says that there's a flank pain radiating to the groin. Okay, understandable. This is renal colic. Then the patient also complained pain to the shoulder region. Okay, and our friend here answered A. Okay, and that's correct. Why? Because sometimes when you have a psoas abscess, it could either ascend or descend. When it ascends, it will go to the diaphragm and it's going to irritate the phrenic nerve, leading to a referred pain in the shoulder region. But if it descends, it's going to affect the hip joint. So that's why sometimes people will come with a psoas abscess complaining from pain in the hip. Okay. So yeah, phrenic nerve is correct because of the pain in the shoulder. All right. During a kidney transplant, the surgeon must differentiate the renal vascular structures. What is the correct anatomical arrangement of these structures at the renal hilum from anterior to posterior? So, what do you think? Yes, it's going to be B. So, most interior, we have the renal vein, and then medially, we're going to have the artery, and posteriorly, we're going to have the pelvis. Um, yeah, I think it's pretty straightforward. All right, so a surgeon plans a nephrectomy and must carefully incise the renal fascia. What other structure is enclosed within its facial compartment? So this could be tricky, but you need to be very sure to read the word enclosed. Yep, it's going to be the suprarenal gland. So as you can see here, so this is the fascia. This is the renal fascia, right? So let's walk through the layers that surround the kidney. So first you have the capsule, the fibrous capsule. Its function is to restrict any hemorrhage that could happen, and of course, provide support to the organ. Then you have the perinephric fat, right, right here. Okay. And then you have the renal fascia. Okay. So within this fascia, as you can see here, this is the suprarenal gland, and it's enclosed entirely within this compartment. All right. So a patient with renal failure underwent kidney transplant. To which vascular structure was the renal vessels attached to? Like, you know, the renal vessels, mean renal artery, renal veins. Uh, yep, it's going to be external ilia. Okay, that's correct. And by the way, they keep the kidney in the pelvis. Like they don't like put it up. They just keep it somewhere down there. Okay, so a patient admitted to the hospital with an abscess that is found in the perinephric fat layer of the kidney. This abscess is confined between which layers? Yeah, I just mentioned it. So what do you think? Yep, that's going to be A. Okay. Um, it's not going to be C because it says cortex, and the renal cortex is literally inside the kidney. So yeah, cool. All right. So at the level of the hilum of the kidney, an artery emerges from the abdominal aorta. What is the level and the artery? Yep, it's going to be B. So there is this transpyloric plane. Actually, let me show you. I think I have it. Yeah. So this is the transpyloric plane. And among this plane, you can see that there could, at level of L1, there are multiple structures that would emerge. The hilum is one of them. And of course, the origin of the superior mesenteric artery. Cool. Okay, so why does respiration cause movement of the kidney? What do you think? Yeah, so it's going to be B, that's correct. But this is because the renal fascia is attached to the diaphragm itself. So, diaphragm is a muscular partition mainly responsible for respiration. So whenever the diaphragm like moves, it pulls the kidney with it. All right. So a 53-old woman, uh, known with a known disease. Do people with nephroptosis get pain and respiration? That's a very good question. Although, however, I don't think so, but I'm not sure. That's a very good question, though. All right. So a 53-year-old woman with known kidney disease presents to a hospital because her pain has become increasingly more severe. Physician performing kidney surgery must remember that. What do you think? So this is a very anatomical based question. Um, it's like true or false, but you just need to choose the most correct answer. Yes, it's going to be D. That's correct. Okay. So the left kidney lies a bit lower than the right one. That's not true. It's actually the opposite. The right kidney lies lower than the left one by 2 to 3 centimeters due to the liver, of course. The perirenal fat lies internal to the renal fascia, and the renal fascia does surround the suprarenal gland, like full enclosed. The left, sorry, the right renal artery is longer than the left renal artery. Okay, and D is correct. So yeah, cool. So a patient presents with loin to groin pain, or another way you can see it as renal colic pain. Cool. A KUB X-ray confirms renal calculus. What is the source of the pain? So what do you think? Uh, yep, sorry for that. Okay, so you said C, right? Okay, so it's not gonna be B because when you compress the ureter, okay, that's not that's going to cause like sensory disturbance, but mainly the reason, okay, for pain, okay, to be felt, especially when it's carried like through the sympathetic fibers and stuff, is when there's spasm and distension of the renal pelvis itself. Okay, that will majorly cause the renal colic pain, the loin to groin pain. Okay, that spasm, that movement is going to, you know, cause these sensory impulses. And like other keyword is distension. Any viscera, when it gets distended, it causes pain. So it doesn't necessarily mean that if you have to compress something, it's going to cause pain. Okay. Um, but usually like distension, spasm, these stuff like uh would cause such pain. All right. So during a hysterectomy, uh, the surgeon must be cautious not to damage the ureter. Where does the ureter lie in relation to the uterine artery? So hysterectomy is removal of the uterus. Okay, so um, okay, you need to be very careful. It says the ureter in relation to the uterine artery. So where does it lie in relation to the uterine artery? So it's going to be anterior and superior. So take a look here. So this is the ureter, okay? And you know, this is like the uterine artery. Cool. The uterine artery is going to be anterior and superior to it, superior to the ureter itself. Okay. That's why it's going to be, interior and superior. I think that like might cause a confusion. So um I hope it's clear. I'm just gonna zoom in a bit. I don't know, can you see the zoom in? So this is the ureter, and this is the uterine artery right here. All right, so renal colic pain radiates to the groin and the upper thigh. This is due to referral of pain from which nerve? Yep, it's going to be the genitofemoral nerve. Like all other have no no role in like sensory you know supply to the kidney or the ureter. Okay, moving on. Um, so a newborn has urine leaking from the umbilicus. Which embryological structure has failed to obliterate? Yeah, you're right. Like the ureter is inferior to the artery, but what that question I meant to ask the uterine artery itself, okay, in relation to the ureter, how is it being positioned? So it's going to be superior and interior to the ureter. So the artery itself, okay, it's going to be superior and interior. The ureter is going to be, posterior and inferior. Yeah, you're completely right. It's water under the bridge. That's right. Yeah. So this is an embryological question. Um, so urine leaking from the umbilicus, which structure failed to obliterate? What do you think? C. It's going to be B, okay, which is the uricus. So this is the uricus right here. Okay. Usually when this part is like embryologically speaking, okay, this would be the uricus, but then with like develop with time, it's going to become the median umbilical ligament, okay, when it obliterates. But if it still persists, it's going to form this thing called the urethral cyst, and it's going to cause urine to be leaking out of the umbilicus. Okay, so it's the urethus. Cool. Um, so moving on, a 45-year-old female presents to clinic with urinary incontinence when sneezing or coughing. She is a mother to six children, previously healthy. Upon examination, what else would you notice? So when you read this question, you have to keep in mind. Uh, so first of all, it's a female. Okay, urinary incontinence. So urinary incontinence in female is usually high due to the very short urethra that they have. Okay, and also she sneezes or coughs. So whenever there's an increase in the intra-abdominal pressure, and she's a mother to six children. Okay, so a history of multiple pregnancies. Upon examination, what else would you notice? What other symptom you would have? Sorry, not symptom, like yeah, actually it's a symptom. So what other thing that uh you would see when you examine this patient further? Yeah, what do you think? You can make like a fair guess. Yep, that's actually correct. So you're going to see a bladder prolapse. Okay, so this is known as cystocele. Okay, so given that she had multiple pregnancies, her pelvic floor, okay, like the pelvic floor, the muscles like levator ani, for example, these muscles would weaken with multiple pregnancies. Okay. You know, yeah, I don't want to go into details, but due to this, the urinary bladder would not remain in position anymore as before. So it's gonna prolapse. Okay. So usually what they would come complaining with, they're gonna come complain that, that there's like a vaginal bulging because the bladder itself is going to prolapse and bulge into the interior vaginal wall. Okay. So this is how they're gonna come and complain it, but they're not gonna know that this is actually their bladder just being out. Okay. So this is it. And this will of course cause urinary incontinence. Okay. And whenever the intra-abdominal pressure would increase. So this is like a perfect cystocele you know, presentation. All right, so a 35-year-old man admitted with acute urinary retention due to urethral trauma. Emergency team performs suprapubic catheterization to relieve the bladder. During this procedure, which layer is not traversed by the needle? When we say traverse, it means like it doesn't like pass through. So what do you think is the answer? Yep. So it's not going to traverse the peritoneum at all. So uh, this is the catheter that they're going to catheterize. Okay. To relieve the retention in the bladder. Other questions you might be asked, uh, what anatomical landmark will help the physician to know that he's going to the right place? It's always above the pubic symphysis. It's literally just above it. So when they feel the pubic symphysis just above it, like I think 2 centimeters, you're just going to insert the catheter. So that's like another question they could ask you, and it does not penetrate the peritoneum at all. Okay, so take a look at the image on the right side. This patient has a calculus. So where do you think this calculus would be? Which part of the ureter? Yes, it's going to be the uretropelvic junction. Now, why wouldn't you say renal pelvis, mid-ureter, or such? Because you need to keep in mind there are three constrictions in the ureter itself. Okay, we have the uretropelvic, the uretrovesical, and when it crosses the common iliac vessels, okay, at the pelvic brim. Cool. So these places are the most common places where the the calculi is going, the calculus, sorry, is going to get stuck. And given their location anatomically, the most correct answer would be the uretropelvic junction. Okay. So what about this one? Where do you think the calculus is positioned? Yep, it's going to be the uretrovesical junction. That's correct. So if you take a look, okay, there's there's like dilation, okay, dilation of the entire ureter, as you can see, okay, and this is because of an obstruction, at the uretrovesical junction, like where the ureter like joins the bladder, okay. If it was the uretropelvic one, you wouldn't see this dilation right here. You would see it just to be, you know, uh, like the renal pelvis would be dilated, the calyces would be dilated, like you'd see a hydronephrosis kind of presentation. Okay, but here you have the entire ureter, okay, being dilated. Okay, well, what is it? What's it? Bro, don't look at the right side. Just keep looking here. I'm not sure, honestly. I don't know what that is. See, if I'm not mistaken, and if I'm making a, no, I don't want to guess. I have no idea. Okay, so let's just. Look at the ureter. Cool. Um, a pregnant woman comes with loin to groin pain. What can be used to safely check for the problem? So, a pregnant woman, radiation. What would be your answer? Yep, it's going to be ultrasound. It's the safest for pregnant women and very easy as well. Like such an easy diagnostic tool in clinic. All right, so which of the following statements is correct about the ureter? Yes, so you're right. Posterior to the uterine artery, just like water under the bridge. Um, so A is wrong because it's supposed to be psoas major. B is wrong because it does not cross at L4. Okay, it crosses nearby to L4, to be exact, at the sacroiliac joint. That's when it crosses the pelvic bridge. And it's not posterior to ductus deferens, it's interior to it. Okay. No, it's interior to it. I think I have a picture somewhere up front. But no, it's interior. C is the only correct one. It's posterior to the uterine artery. Okay, so a 50-year-old man undergoes cystoscopy for evaluation of hematuria. So cystoscopy is when they need to check for the bladder. Okay. The urologist notes smooth mucosa over the trigone with visible slit-like ureteric orifices. What are the boundaries of the trigone of the bladder? Yes, it's going to be. So as you can see, this is the trigone. This is the bladder. And, they do a cystoscopy to check inside. And this is the, where the ureter just, you know, opens up into the bladder, right and left ureteric orifices. This is the internal sphincter, internal urethral sphincter right here. Okay, and this is a smooth part. This is how you know this is the tridon. And this is the wall of the bladder, which is the detrusor muscle. You can see it's trabeculated in nature. Anyways, and this would be your prosthetic urethra, and this would be the external sphincter. And yeah, okay, it's moving on. So a 55-year-old female presents with symptoms of pelvic discomfort and mild urinary incontinence. She has a history of 3 vaginal deliveries and is scheduled for a gynecological surgery. During the surgery, the surgeon carefully ligates the branches of the internal iliac artery supplying the bladder. However, bleeding is noted, and the surgeon identifies an additional arterial branch that supplies the bladder in females. Which artery is most likely supplying the bladder in this patient? A trick that helps me remember is I think of the organ and its anatomical relations with other organs. So, what do you think the answer would be? No, it's not C. Think. What do you think? Okay, so it's going to be B, the vaginal artery. So, first of all, if you take a look, or you can't see it here, but the bladder itself, okay, is in relation with, you know, in the proximity with, like the interior wall of the vagina, right? So this is something that can help you remember it. And superior vesicle, it's usually the inferior vesicle, not the superior vesicle that supplies the bladder. Okay, it's usually the inferior vesical artery and the superior umbilical artery. Um, in men, okay, in males, you would have as well the inferior vesical artery. Okay, as I mentioned, but in females, it would be replaced with the vaginal artery. So that's worth knowing. Cool. So the physician suspects an obstruction in ureter on the side when it pierces the bladder wall. So they're talking about like the uretrovesical junction. Which of the following is the level of obstruction? Yeah, it's going to be the ischial spine. That's correct. So this is the ischial spine right here. This is, like pelvic brim and, sacroiliac joint. The ureter comes down, and then this is where the bladder is located, and it joins in. So it's somewhere at the ischial spine. Sacroiliac joint is way higher. That's actually uh, you know, the uh, the pelvic brim, as I mentioned, and the L1 is as well higher, L3 higher, T12 higher. They're not at the same level. So the answer would be the ischial spine. Okay, so what is the primary function of the internal urethral sphincter in males? And this is very important to understand complications of things like prosthetic prostatectomy. So what do you think? Yep, it's going to be A, retrograde ejaculation. So let me just go back a bit. So this is the prosthetic urethra, right? This is your internal urethral sphincter. Now, in the prosthetic urethra, there will be a bulge, okay, in this wall right here. And this there you would find it's called, I think, the seminal collicus, something like that. Okay. And you're going to have ejaculatory ducts and you're going to have the prosthetic orifice where you would have, semen coming out. So imagine, okay, that there's no internal urethral sphincter. Semen is going to flow the other way. So that's called retrograde ejaculation. Okay. So that's why, with the help of internal urethral sphincter, it prevents retrograde ejaculation in men. Okay. A 65-year-old man presents with difficulty urinating, nocturia, and a weak urinary stream. Digital rectal examination reveals a smooth, enlarged prostate. What is the most likely zone of enlargement in this patient? So first of all, what do we think? What's the diagnosis like? What do you think? Given that it's a smooth, enlarged prostate, smooth surface, like it's pretty firm. So it's going to be BPH, yes, benign prostatic hyperplasia. So which zone would be enlarged in patients with BPH? Yep, that's going to be the transitional zone. All right. A 72-year-old man presents with back pain and difficulty urinating. DRE reveals nodular hard prostate. Imaging shows metastasis to the lumbar vertebrae. Through which venous pathway did the cancer spread? No, it's not B. Okay, I'm going to explain it to you. It's actually going to be C. So, yeah, it's C. So let me explain why it's C. So we have the prosthetic venous plexus, okay? And, what drains into it, it's going to receive blood from the dorsal vein of the penis, and they're going to drain into the inferior vena cava. Now, on their way, they pass by the vertebral venous plexus. They're valveless. They have no valve. Okay, so on their way, given that they have this valveless characteristic, okay, they're going to spread the tumor through it. Okay, with the other name for vertebral venous plexus is the Batson's plexus. Okay, and one of the first signs of metastatic prostatic cancer is back pain. Okay, so if you see if a question comes like a male, like a 65 and above, um, and with back pain, difficulty urinating, you need to think of prostate cancer as number one. Then comes BPH. But since the DRE was done and it was nodular and hard, then it's definitely cancer. And this is how it spreads. I think 3 years ago when I was first here, I think this was a question in the SAQ. I'm not sure, but definitely we were asked. Okay, so a patient has lost control of the urination because of paralysis of the external urethral sphincter. Which nerve is responsible for the external urethral sphincter? Yes, it's going to be A, the pudendal nerve. Correct. Okay, so during catheterization, which structure is most likely to be injured? Yep, the membranous urethra. It's very narrow and delicate structure given the term membranous, so definitely would be injured or like high risk of injury. All right, so a urologist performs a transurethral resection of the prostate in a patient with BPH. Which structure is most at risk of injury during this procedure? Wait, did you answer? Yeah. Yeah. So yeah, it's going to be the internal urethral sphincter. So the transurethral resection is like when they insert um, you know, this surgical instrument and they try to, remove the part that's blocking the urine just from flowing right down there due to the enlargement. So they're just trying to, just cut it off, clean it out. While doing that, there's a very high chance that they're also going to remove part of the internal urethral sphincter. Thus, it's going to injure it. Either it weakens or it doesn't function anymore. Cool. So what is the role of the sympathetic fibers in Mctrusian reflex? So sympathetic, what do you think? Yes, it's going to be C. It's going to inhibit the detrusor muscle contraction and stimulate the internal urethral sphincter. So this will inhibit emptying because, sympathetic, uh, it works on, not not emptying the bladder. So this is also very, very important when, a male is having sexual intercourse, for example, because this will cause the internal sphincter to just like contract and prevent retrograde ejaculation. But let's say it's quite the opposite, where they need to facilitate emptying through parasympathetic fibers. It's the opposite. It's going to stimulate the trusal muscles to contract, which will cause emptying of the bladder and the relaxation of the internal urethral sphincter. Cool. Renal carcinoma commonly metastasizes to which of the following sites? First, like 50% of the times, you're going to find it there. Yep, that's going to be the lungs. So let's actually at the same time take a look and appreciate. So this is the kidney right here. And usually whenever there's like a tumor, okay, uh, one of the first thing that happens is going to break the fibrous capsule, the renal capsule it has, so it spreads. And as you can see here, it's already spreading. And one of the sites that it's spreading to is the right renal vein, which then is going to end up going to the inferior vena cava. And then, other symptoms they're going to have is hematuria, for example, or like a mass in the abdomen. And, as it metastasizes to over 50% of the times, you'll find it in the lungs. So just something, just for you to know, okay, whenever you need to judge a CT scan, um, or like whatever, like cross-sectional, and you need to see if there's renal carcinoma or not. One of the first things you need to see is the, uh, you know, is the external uh lining of the kidney, is it smooth or is it not? Okay. Like is it as you can see here, it's not consistent with the rest of the kidney. So this could indicate maybe that there could be a mass, something growing, something that it could be blood, it could be tumor. Okay, cool. So let's take a look at this image right here. So what imaging modality is this, and what can you see by the red arrow? Okay, it's a CT scan. Cool. And it's a renal calculi or renal stone. Yes. So takeaway is stones on a CT scan would be very bright. Okay. And yeah. Okay. So a 35-year-old man presents to the clinic with a 2-week history of worsening lower back pain and intermittent fever. He reports difficulty walking and has noticed pain radiating to the hip. On physical examination, there's tenderness all over the lower lumbar spine, and the patient displays difficulty extending the right hip. Imaging was obtained. What is your diagnosis? So what do you think? There's back pain, there's fever, could indicate infection, and there is um, you know, hip joint pain. Yes, it's going to be a psoas abscess. So either you can tell from the symptoms, the presentation, or you can tell from the scan itself. So if you compare it, so this is like the kidney, okay? And you can compare there's a mass here, okay? So this is a psoas muscle, and there's psoas abscess right here. So yeah, you can tell from both the CT and the symptoms. And in this scenario, okay, we can tell that the psoas abscess have descended, right, to the hip joint, given that they cannot extend their hip and there's pain. So yeah. Okay, so uh what do you think what do you think the modality is used here and what can you see? Okay, yes. So this is a retrograde ureterogram, okay, showing a double ureter on the left, as you can see. Yeah, moving on. So a 25-year-old woman presents for evaluation of abdominal discomfort and urinary frequency. She has no significant past medical history. The physical examination is unremarkable. Laboratory findings reveal no abnormalities. An abdominal ultrasound performed for further evaluation. What is the most likely complication arising from this? So, first of all, let's diagnose. What is this? What are you looking at? What do you think? So, to help you, okay, let's look like, okay, we know this is a kidney. We can tell from the calyces, pelvis, ureter, but to their positioning, okay, their positioning is very low, exactly as you mentioned. So they're very close to the pelvic brim, okay, and they're very close somewhere to the sacroiliac joint down there. So what do you think? And it's not just one kidney, it's both. And yes, you mentioned that it's a bit quite inflated. This is an image of horseshoe kidney. Okay. This is how this is how it's gonna look like. Okay. So what do you think is one of the most likely complications arising from having a horseshoe kidney? And I think you can also tell by the image. Yep, it's going to be A. It has nothing to do with autoimmune. There will be increased risk of nephrolithiasis, which means kidney stones. And we can already see them like it's pretty enlarged. So yeah, you're correct. Okay, so during prosthetic surgery, the nerves that innervate the prostate are damaged. This would lead to erectile dysfunction. Which of the following additional symptoms is most likely to occur? Yep, that's going to be retrograde ejaculation bladder. Because remember, um, the internal sphincter nerve is supplied by sympathetic fibers. Okay. So did I say nerve? I mean the sphincter, the internal urethral sphincter. Okay. So they're all like supplied like from the prostate nervous plexus. So damage to that could also affect the sphincter, leading to retrograde ejaculation. Okay, so what is the vertebral level of the origin of the celiac trunk? Yep, that's going to be B. What about the inferior mesenteric artery? What do you think? Yes, it's going to be L3. And superior mesenteric? Yes, L1. Okay, so what is the structure that is inferior to superior mesenteric artery? What do you think? Yep, the left renal vein. So any obstruction to the superior mesenteric artery is going to cause compression to the left renal vein, leading to varicocele on the left side of the scrotum. And this is actually called the nutcracker syndrome, okay, caused by the superior mesenteric artery. I think it was asked in one of the past exams. I saw it somewhere there. So yeah. Anyways, good anatomy checkpoint, I'd say. So uh we have two questions left and we're done. So the lumbar plexus lies within which muscle? What do you think? Yeah, so it's going to be within the source medium. Correct. So you'd have the source and literally right behind it, as you mentioned, or even like within it, okay, you'd have the lumbar plexus. Cool. Which two nerves arise from the L1 segment of the lumbar plexus? Yep, that's going to be B. All right. Moving on to our last MCQ. At what vertebral level do the kidneys typically lie? Yep, and that's going to be C. All right. Oh, there's one more. Cool. There's one more MCQ, and there are two clinical scenarios. So please stay. What's the most typical location of the staghorn calculus? What do you think? Yeah, صراحة يعني me too. I'll be confused between both of them, but the most typical one would be the major calices because even like when you see the staghorn itself, it takes the shape of the major calyx. Okay. And as it takes its shape, this is why it's called like a staghorn. Okay, because it also takes the shape of all these major calyces within the kidney. Okay, so the most typical lesion would be the major calyces. Okay, like so these clinical scenarios, uh, they're very typical, which show up either as an MCQ or SAQ, or even an OSPE. So um, it's beneficial to go through them. So let's start. So this is an 85-year-old man presenting to a clinic with backache, weight loss for the past 7 months. Denies difficulty in urination, dysuria, hesitancy. Dysuria is like pain while urinating. Okay. Upon physical examination, the abdomen was soft and not tender. Upon DRE, one of the lobes presented to be hard and nodular. Serum acid phosphatase is elevated. So whenever you get a clinical case, okay, you need to investigate each and every word in the scenario. So an 85-year-old male already, very high on the spectrum of having cancer, prostate cancer, okay, backache and weight loss. Okay, this could indicate something which you need to answer. And upon DRE, one of the lobes were the hard and nodular. So, this could also make you think of a top differential when you need to diagnose this patient. And also, this clinical case is so good that it even told you that the serum acid phosphatase was found to be elevated. So, what do you think is a diagnosis? Yes, it's going to be prostate cancer. So, the age, the DRE findings, and the serum acid phosphatase are all three indications that this is a prostate cancer case. And this is not BPH. Why is this is not BPH? Because there's no urinary frequency, no hesitancy, and no dysuria. Okay? Play it. Name two other diagnostic tools that you could use to confirm your diagnosis as prostate cancer. What do you think? What other two things you would do? Okay, so but they already did DRE though. So yeah, you would do something known as the PSA, prostate specific antigen. And see, whenever you find something like a mass or there's like something that's found to be hard and nodular, just do a biopsy. You know, you need to confirm. So you need to confirm the histopathology aspect. So just do a biopsy of the tissue. So two other things I would do. is the PSA and doing a biopsy, of course. So let's explain the anatomical basis of backache. Why did this patient complain from backache for the past 7 months? And also, let's answer the last part of it. What does it indicate as well? Having backache and weight loss. Okay, so yes, that's very correct. It indicates metastasis to the vertebral. Uh, so yes, it indicates metastasis of prostate cancer. And the anatomical basis behind backache is there's metastasis to the vertebral venous plexus or the Batson plexus. And how that works, again, we have the prosthetic venous plexus receives blood from the dorsal vein of the penis, and then it's going to go and drain into the inferior vena cava. On that route, it passes through the vertebral venous plexus, which are valveless. And because of that, a very easy, seamless process where the metastasis is going to happen. And thus, one of the first signs of prostate cancer, metastasis of prostate cancer, is backache. Good. Mumtaz. Which zone of the prostate is enlarged in prostate cancer? What do you think? Peripheral. Yep. Good. Will BPH بيكون yep, transitional. Cool. طيب, let's do our last scenario. So this is a 78-year-old man presenting to the clinic with difficulty in urination, dysuria, hesitancy, feeling of incomplete, emptying of the urinary bladder, and nocturia for the past 6 months. Okay, so during physical examination, the abdomen was found to be tender in the suprapubic area, and with DRE shows enlarged, firm prostate. Okay. Oh, sorry, I didn't see your question. Uh, okay, so for the first case, one of our colleagues is asking why weight loss. Um, why weight loss? I actually forgot. I don't know why. I forgot why we have weight loss, but see, it's one of the signs in cancer, but I forgot. I'm sorry. Uh, we can do a PET scan. Uh, in radiology, we can do something known as PET scan. It will show you the metastasis. I can show you after we finish this scenario. We can do a PET scan. It's going to show you exactly how it metastasizes through the entire vertebra. Okay, so back to this case. What do you think is a diagnosis? Yes, it's going to be BPH, benign prostatic hyperplasia. Like, why is it not prostatitis? How would prostatitis be different on a DRE? Because this says it's enlarged and firm prostate. So if it was prostatitis, how's it going to be? Yeah, it wouldn't be firm. So it's going to be soft and tender, okay, upon examination. So prostatitis would be soft and tender. Okay. Can you explain to me the anatomical basis of the lower urinary tract symptoms demonstrated by this patient, which is, difficulty urinating, dysuria, hesitancy, feeling of like incomplete emptying. Okay. I wouldn't say narrowing of the prostatic urethra. Uh, I would start by saying, you mean the passage, right? From the from the bladder to the prosthetic urethra is narrow, right? Is that what you say? Is that what you're saying, right? Like decrease in surface area there. Because that's what I would pick up from what you're saying. Okay. So let me explain to you. So we have this thing called as the ball valve effect. So what happens is that the medial lobe, okay, of the prostate is going to enlarge and it's going to protrude, okay, as the transitional zone enlarging. This is going to, of course, yani, distort the internal uh urethral sphincter, leading to sphincter incompetence. That's one. So this is going to cause dribbling of urine. Yani the patient doesn't even have the urge, doesn't even feel like going, and suddenly they're just having dribbling of urine. So this is number one, sphincter incompetence due to the protrusion of the prostate, طيب, or يعني the benign hyperplasia part. So that's number one. Number two, you're going to have uh because of the prosthetic urethra, as you mentioned, is going to be like affected and narrowed, that's going to have an obstructed urinary outflow. Okay. This means that there will be some urine going to remain in the bladder. This residual urine is going to trigger, okay, the trigon. So the trigon works as, it's like it's gonna feel like it's gonna feel like the level, like is there urine or not? So there's urine in the bladder. So it's going to trigger the feeling that you need to go, this urinary urgency that you need to go and empty your bladder. Okay. Thus, you'll also have such feelings like nocturia. You need to wake up in the middle of the night to go and urinate. But as a matter of fact, you know, there is not, yeah, you don't just, there's this feeling of incomplete emptying. Okay. Due to this, urgency, nocturia, incomplete emptying is because of the triggering, of the trigon, right? Being activated multiple times, okay, due to the residual volume. Why? Because there's an obstructed urinary outflow. Okay. So yeah. And then because there's dribbling of urine into the prosthetic urethra, this will irritate it and will cause urgency, the feeling that that you need to go and urinate. So to sum it up, you will have protrusion of the prostate, right? And this protrusion is going to affect the sphincter. So you're going to have an incompetent sphincter that will lead to dribbling. So this is basically out of your control. This dribbling will irritate the prosthetic urethra, causing urgency as well. Then this protrusion itself is going to also, um, you know, narrow the urinary outflow. As a matter of fact, obstruct the urinary outflow. So, this will cause urine to retain in the bladder. This residual urine, like the bladder is not going to be emptied fully. There's a bit of it that's going to remain. And this remaining urine, this residual urine, is going to trigger the trigon to be activated, which will cause the feeling of nocturia, frequency, urgency, all of those. So this is known as the ball valve effect, okay, when there will be a protrusion of the prostate into the bladder. Anyways, I hope I explained it to you. So moving on, how do you expect the appearance of the bladder internally to look like? Okay, no, not entirely though. That's only the trigon. That's going to be smooth. But the bladder, uh, since like its activity, okay, being just like a bit, heavy and that it's going to be trabeculated. Okay. Play. Lastly, the patient was scheduled for a urethral prostate resection. Which structure might be injured in the process that will lead to patient infertility? What do you think? See, that's only the cavernous nervuses would be correct when we're doing surgery to remove the prostate, yani when there's a prostate cancer, when you're doing like a prostatectomy, for example, that's going to cause erectile dysfunction, right? Um, but here you're doing a urethral prostate resection, like you're going through the urethra. Okay. So you're going to the urethra all the way to the prostate urethra, and then you're going to remove, uh, the protruding prostate. So while you're doing that, what's going to be affected? Yep, exactly. That's going to be the internal sphincter. Why is it going to, increase the chance of the patient infertility? Because of retrograde ejaculation. Okay. And yeah. So, do you have any questions? I think till now we've concluded renal anatomy practice questions. Thank you so much to being all the way till the end. You can scan the QR code to give like your generous feedback. And yeah, يعطيكم ألف عافية. Good luck on your exams.